Hello everyone, and welcome to another CME session for ADHD in adults. This is integrating pharmacologic and non-pharmacologic treatments, an evidence-based approach. This is going to be a very interesting presentation because we've heard so much about pharmacologic treatments and we've heard separately about non-pharm treatments, but now they can be integrated and how to do those well. Our presentation is presented today by Dr. Stephen Ferrone, PhD. He's the professor of departments of psychiatry and neuroscience and physiology at SUNY Upstate Medical University. And on the left, you'll see Dr. Ferrone, and on the right is myself, Jonathan Marks. I'm the Senior Vice President of Inkwell Medical Communications. This is brought to you by three different organizations. APSARD, the American Professional Society of ADHD and Related Disorders, brings us all of our professional presenters. Dr. Ferrone has been on the board of APSARD and is a member as well. This is accredited by NACE, the National Association of Continuing Education, and this presentation is produced and disseminated by Inkwell Medical Communications. Go ahead, Steve.
Okay, well, thank you, Jonathan. First, we'll just quickly show you some of my disclosures. I do consulting work for pharmaceutical companies, have a patent, and also publish some books from which I make income. One of the books is relevant. I do have a book that is a review of non-pharmacological treatments for ADHD that we recently published with Kevin Anschel. It's an edited volume. But most of what I'm presenting has very little to do with the disclosures I present here. First, let's talk about evidence and how to evaluate evidence. I'm sure you've all heard the phrase evidence-based medicine and what that means. An important point about evidence-based medicine is that it doesn't mean that we can only, as clinicians, use methods that have gold standard evidence, meaning double-blind, placebo-controlled, randomized clinical trials. It doesn't mean that. What it does mean is that we should use the best level of evidence available when evaluating a treatment, and we should use a treatment that has the best level of evidence and the best effect. Now, there's really two pieces of that. One is the quality of the evidence, so how good was the trial designed to provide information about outcome. And frankly, for some treatments, there's not a lot of evidence. We only have observations of, say, cases. For rare diseases, sometimes you only have 4 or 5 cases where there are observations by clinicians who have done something that works. And in that case, that's the best evidence, and that's what we need to use. In other cases, we do have the randomized controlled trials. In that case, that's what we should use. In addition to quality, we also have to think about the magnitude of the treatment effect. So we can have a treatment method that has a high level of evidence for efficacy, but it just might not work very well. On the other hand, you could have a treatment that has a lower level of evidence that appears to work very well. And we have to figure out how to balance those two things when making decisions about treatments. The non-pharmacologic methods for treating ADHD have been reviewed in depth by a good friend and colleague of mine, Edmund Sanuka-Bark, in 2013. I highly recommend this article in the American Journal of Psychiatry. What he's looking at here are standardized mean differences. When you think about that, it is a way to compare two treatments that may have been developed using different measurements, but to compare them on a similar scale, so we can say which one's better than the other one. So that standardized mean difference, sometimes it's called Cohen's d, for those of you who have heard that term. It's a measure of effect, therefore it's also called an effect size. It's one of many effect sizes, but it's very commonly used in looking at clinical trials when comparing placebo and control on some continuously varying rating scale. So in this case, Professor Sanuka-Bark is looking at the evidence for behavioral interventions. This is for studies, these are studies of children, and much of what we're going to say is going to be relevant to studies of adults, but these behavioral studies are just strictly kid studies. And he's got these studies ordered here in terms of least favorable to most favorable towards the actual efficacy of treatment. Each study is represented by a red square, and that red square is the effect size. So if you look at the very bottom, this study by Thompson in 1974 showed an effect size of about 1.3, and then this band is a confidence interval, the 95% confidence interval. And because this confidence interval is greater than 0, we know that this study found a significant effect of behavioral treatment. Now this blue box at the very bottom, this is if we pool all these studies together, we say, what do they say as a group? Well, what does it say? It says that there is a significant effect of behavioral treatment. It's really small, it's about 0.3, but it's very significant. The confidence bounds are very small because it's based upon all these studies. Two important things to point out here. One is that although overall it's significant, the effect is small. We can compare that to, for example, for stimulant medication. The effect of stimulant medications on ADHD is between 0.8 and 1.0, sometimes a little bit higher. The effect of non-stimulants like atomoxetine, guanfacine, clonidine, that's more like around 0.6. So these studies seem to suggest that this overall SMD of 0.4 is worth considering. However, these were the data on the left here from all the studies that were examined. If we go on the right-hand side to what are called probably blinded studies, meaning what Dr. Snugabark and his colleagues did is they went through these papers very carefully and they said, were the raters who were rating outcome, were they blind to who was in the placebo group and who was in the treatment group? Mm-hmm. What they found is that they had to toss many studies out because many of them were not properly blinded. And when you get rid of the bad studies, what you see is that the effect is actually zero. The blue box is a summary of all these studies. No study found in the right-hand side found a significant effect, and taken together, they're estimating a value of zero, which is what you'd expect for a treatment that doesn't work. So their conclusions from this study is that the current data do not support the efficacy of behavioral interventions for children. The important point that I want viewers of this slide to take away, and of subsequent slides as well, is it's very important to consider the quality of the study, particularly around whether the placebo and drug groups are blinded to the rating of outcome. So that was for behavioral studies. Cognitive training, there are many methods of cognitive training. These are the types of studies that typically use a computer-based method where somebody's looking at a computer screen. Sometimes they're playing a game, sometimes they're solving problems. The idea is you're training the brain to do better at some task. And the hope is that those tasks would improve and that the person's ADHD would improve. Now, in this presentation, we're talking all about whether these methods help ADHD. So I'll emphasize here that there are some data suggesting that cognitive training is good for helping certain types of cognition, like improving someone's memory could be one example, that some of these methods can be useful for improving memory. But are they useful for treating ADHD? Well, the quick answer we can see is if you go, now that we know that the best studies are the probably blinded ones, we can see that overall they had an SMD, or a standardized mean difference, of 0.2, which was just statistically significant, that p equals 0.04. And so as a group, these studies do suggest that there's some evidence for the efficacy of cognitive training, but importantly, the effect is very tiny. We can see from the SMD of 0.20 on the bottom right here that the effect of cognitive training, although it is statistically significant, is not very big. It's much smaller than what we'd see for stimulant therapy, which is about 0.8 to 1.0. And that means that most people who would use this therapy would not benefit from it. Mm-hmm. Looking again at the left-hand side, when you consider every study that's been considered, we see the same phenomena we saw in the prior slide, that the effect seems bigger and it's much more significant. But that's only because there are studies in the left-hand side that did not properly blind the raters when they were rating outcomes.
Steve, two questions. Can you describe a little bit more what you mean, and you intimated that in what you just said, but what do you mean when you say probably blinded, and why does that matter?
Okay, thanks for asking that question. The choice of words is not mine, it's my colleagues, in this case, Samuel Cortese, which is the same group as Edmund Snugabark, it's the same group of people that are doing this. They chose that phrase, probably blinded, because they didn't themselves run the studies. It's impossible for them to know all the time whether studies were definitely blinded. It's very easy to determine blinding for a drug study, because in the drug study we read the method section and we find out whether capsules actually in placebo, put in placebo capsules versus drug capsules. And in the drug study, the placebo and the drug capsules look identical, so the blinding is very real, and there's no question whether it's probably blinded or not. It actually is, it's definitely blinded. Mm-hmm. But the problem with psychosocial treatments is that it's not always clear whether people were blinded. So, for example, an obvious case might be if someone is doing parent training in a study and they're also doing the ratings, well, if they're doing the parent training, they know who's getting the real parent training and who's not. And so they're definitely not blinded. Those studies are easy to kick out. But there are some cases where it might be a different rater, but it's not clear whether that rater had information about the group assignment, and therefore they might decide to kick it out, or they might say, it's probably blinded. It looks like, it seems that it was blinded, but we're not 100% sure. Right. And so there is a bit of judgment here when they're saying probably blinded. But even if they were making errors in that regard, it wouldn't explain the effects that they're getting. That because as they toss these studies out that are more suspicious, they get lower effect sizes and lower levels of statistical significance.
And go one level deeper for me. What does it matter if it's blinded or not blinded?
Good point, because If a study is not blinded, we know from lots of literature that there's this expectancy effect. The placebo effect means that there's an expectancy of getting better.
Mm-hmm.
And that expectancy is not just something that the patient has, it's also something that the people running the study have. They're running the study and the investigators say, okay, we're trying this new great treatment for ADHD. We think it's going to be a real phenomenal treatment that's going to replace medications, and we're really happy to have you on board to help us do this. So the person typically coming into a study that's working in the study, the investigator obviously believes that the treatment works. They wouldn't be studying it otherwise. And so the enthusiasm of the investigator, if you will, infects the rater. So the rater becomes enthusiastic. And it's very easy for someone to not consciously, we're not saying people are cheating, it's an unconscious effect. It's
Right.
kind of an automatic effect. You feel good about it, and therefore people will appear to do better.
Mm-hmm.
We see that even in unblinded drug trials. In unblinded drug trials, people do better than in blinded drug trials because the effect seems bigger because both the patients and the raters have this expectancy that it will be better.
Got it. Thank you for explaining that. And the second question,
Sure.
Here you're showing the effect of cognitive training, let's say at a 0.3. Previously you said the effect size for pharmaceuticals is about 0.8 or 0.6 for non-stimulants. How significant is the difference between a 0.3 and a 0.6 or a 0.3 and a 0.8? It doesn't seem very big, but is it?
It actually is pretty big. So for those clinicians who are used to treating ADHD, you know the difference between a stimulant medication and, say, atomoxetine, guanfacine, or clonidine in terms of how efficacious, the difference in the efficacy between the stimulant class and the non-stimulant class. That is a 3-point difference, roughly, a 3 to 4-point difference, and it's a fairly big difference in terms of how well people are getting and the number of people that are improving. Mm-hmm. So the difference between a 0.2 and a 0.8 is huge, and it's mm-hmm. definitely clinically significant, and even between a 0.2 and a 0.6, I would also say that's a very big difference.
Okay.
Now, there are many parents who don't want their kids to be on medications. And so sometimes a treatment that is not going to harm them, at least from the parent's point of view, they're concerned about the adverse effects, this type of treatment might be more appropriate in that case.
Right.
But the parent needs to know that they're taking the risk of not treating their child 100%, or if an adult is doing this and doesn't want to take medication, they have to understand they're taking a risk that their ADHD might not get treated as well as a medication. On the other hand, they might be lucky, and there will be a small group of people who do pretty well on this particular kind of treatment, this cognitive training.
Right. Thanks for explaining those 2 points.
Okay, and then let's move on to comparing some of the different outcomes that are measured with cognitive training. So I mentioned before that cognitive training has been used for ADHD symptoms, which we just saw on the slide before. And that's at the bottom of this slide, where we're listing ADHD symptoms, and we have this orange bar, and that asterisk says it is statistically significant. And here what we're plotting on the horizontal axis is the effect size. And you can see that there's a difference in effect size depending upon what we're measuring. So for ADHD symptoms, it was significant. I'm not showing the significance here for these two subgroups, but actually the two subgroups weren't significant only because there were fewer studies that actually looked at them, so it didn't actually attain significance. But clearly, if the full symptom count is significant, these two should be significant. Mm-hmm. But there weren't really enough studies to show that. There was high significance, very high significance, and a bigger effect size for memory, both verbal and visual working memory. And that makes sense because the cognitive training was trying to train memory as one of its major goals. Mm-hmm. And therefore, people are actually learning and doing well and doing good in their memory, even on these probably blinded assessments. They didn't do so well in other areas, such as arithmetic, reading, attention, and inhibition. So it's also important to think about what is the outcome that's being measured. So someone might publish a paper and says, oh, this is good for ADHD, and we have this big effect size, and it's highly significant, but then it's only until you read the paper you find out what they're saying is it's good for working memory in ADHD, but not necessarily for ADHD itself. So to summarize, we want to keep in mind what is the outcome being measured when someone says it's good for ADHD. Do they mean it's good for ADHD symptoms, or do they mean it's good for something associated with ADHD, such as a working memory impairment?
Right. So in the previous slide, you showed out of this same research group, Cortese, a 0.3 effect size for cognitive training. But here within this, as you go into the paper and analyze it, you're seeing some pretty significant effects on working and verbal and visual working memory.
Right, but to be clear, the previous slide, it's really point 2 on the right-hand side. Remember, these are the probably blinded assessments. So this point, it's point 2. And then in this slide here, the same thing. The point 2 now shows up. This is the same data here at the bottom, point 2.
For the symptoms.
And absolutely, we're seeing for the symptoms, right? So we're seeing bigger effects for working memory than we are for symptoms, absolutely.
Great.
We can look at a similar type of graphic for behavioral outcomes, behavioral interventions that are probably blinded. So these are the good studies. And as I said before, no effect in ADHD symptoms. We can see that here in the very bottom. It's almost 0. On the other hand, for some kinds of outcomes, the behavioral programming was actually working. So conduct problems, these refer to serious behavior problems, acting out, arguing with parents, getting in trouble with the law, things of that sort. The behavioral training actually had a significant effect, and not huge, but large enough to be considered as a useful treatment, point 3. Parenting skills clearly went up. The effect size there was 0.6, so the training, parents are actually learning to do the training. This means that positive parenting is improving and negative parenting is improving, meaning their parents are using less techniques, less of the bad techniques, and they're using more of the good techniques. So again, it depends upon what the outcome is when we evaluate whether a program works or not. I can give you some guidelines for how you think of evidence. These are not my guidelines. The Oxford Center for Evidence-Based Medicine is probably the premier group of people that have worked on this. And if you go to their website, just Google Oxford Center for Evidence-Based Medicine. Go to the website, you can learn a lot about how evidence-based medicine is defined, how it works, how they have nice handouts. So what are the guidelines that the center thinks about? Well, first of all, if they're interested in, whenever possible, mechanism-based reasoning. Is there a rational mechanism for why something should work? That's part of evidence, but that's like the lowest level of evidence. So I might say, well, ADHD kids misbehave, so therefore parent training should work. Or ADHD adults have trouble being organized, therefore if I train them with cognitive behavior therapy and give them a module on how to organize yourself, that should work. That's a mechanism-based reasoning, and that is a level of evidence. If that's all you have to go on, then you have to go on that and make your decision based on that alone. The next level up is a case series or some small case control studies or studies that are controlled with what they call historical controls, meaning they compare people given the treatment with people who had not been given the treatment a year before. These are considered to be, again, better than just simply mechanism-based reasoning, but not as good as number 3, which would be a controlled follow-up study of a cohort. That's not randomized here. Now, sometimes studies cannot be randomized. There are certain methods of treatment where one can't use randomization because patients won't accept randomization, and therefore what one does is just uses a cohort that's been in the clinic, and you look at people that were treated with different medications, and we see which works best. I did that back, I think it was in the 90s, we were looking at bipolar disorder in kids, and we didn't have enough data to decide how to run what kind of placebo-controlled study to run, and we just reviewed charts, and that produced useful data, which eventually led to better trials. Number 4 is the best type of study one can run as a randomized trial, which is blinded, of course. So it's a randomized controlled clinical trial with blinding of the ratings. Lacking that, sometimes an observational study where there's a very dramatic effect is also considered to be a good level of evidence. In psychiatry, we don't need to use those, but it's conceivable that could happen. But that's rarely, mostly in psychiatry, we rely on randomized clinical trials for the 4th level of evidence. And the 5th level of evidence is the systematic review or the meta-analysis, which is what I've been showing you in the previous slides. When people compute effect sizes from many studies, that's a systematic review, and preferably a meta-analysis, meaning it's quantitative. And that's using randomized trials is the best. In some areas of medicine, we don't have big randomized trials. We only have single patient trials because it might be a rare disease. And that's also considered to be a high level of evidence if it's a good systematic review of many trials. So quality of evidence is important to think about when you're evaluating a specific study. And certainly a good review, especially one that pays attention to the quality of the studies and the blinding, is the best way to go at it. So let's take a kind of bird's eye view, if you will, of the quality of evidence from different types of ADHD treatments. And this is a review I did with my colleague Kevin Anschel a few years ago in the Child Psychiatric Clinics, which is actually a book that's published as a journal too. It's a hardcover book published as a journal. I've ordered the treatments here from highest to lowest in terms of their effect size. The effect size is what's plotted in the horizontal axis here. It goes from 0 up to 5 or 6. And that's our standardized mean difference that we've seen before in this presentation. At the very top are the FDA-approved medications, and the quality of evidence is very high. Clearly, FDA registration trials are outstanding, and we know that the quality of evidence we're getting from those is very good. But there are also some very good trials from other types of treatments, such as omega-3 fatty acids, school-based interventions for kids, summer treatment programs, different behavioral programs, lots of good data there. There are some trials of artificial food color exclusions which are pretty good, not quite as good in terms of level of evidence as the other studies, but still, the level of evidence is up here around 4, so that's still pretty good. And we see this for some dietary studies, neurofeedback, which is a type of cognitive training, family therapies for ADHD, interventions in schools. Now, level of evidence starts to get lower with some pretty interesting interventions, particularly exercise. There's a lot of work in exercise now, and I expect in the next few years we're going to see some very good clinical trials here. There are some studies of herbs. A lot of these are out of China, which are showing interesting effects, but the quality of evidence is still too low to be happy with them as being good data sources. People have talked about iron supplementation and zinc supplementation. Here's an example and it's an unusual example for ADHD where geography matters. There are areas, particularly in Iran, where people suffer from severe zinc deficiency, and there are a number of papers there that show when you take zinc deficient people that have ADHD and you supplement them with zinc, they do better. But again, the quality of evidence isn't great, but it's pretty impressive when you look at those papers. But I wouldn't recommend this for all ADHD people, only if there's zinc deficiency. Exercise, that's repeated twice, it shouldn't be, but it's there. And then we have cognitive behavior therapy for adolescents, which is does not have such good data anymore. We didn't put cognitive behavior therapy for adults, but that actually is a high quality of evidence that's missing from this figure. And then there's some other methods down below where we talk about probably the lowest level of evidence is for psychotherapy and for social skills training. Now remember, this is just level of evidence, the quality of the work, not how good the treatment is. It's just the quality. So when we say that FDA-approved medicines and omega-3 fatty acids are the same level of evidence, we're not saying they're equally efficacious. We're just saying the studies are equally good. For efficacy, we have to think about this next slide, which is refer to the magnitude of treatment effect. Here I've limited it to studies where we have a lot of data on treatment effect. In this case, larger is better. This is our standardized mean difference we talked about before. And as you can see, stimulant medications lead the pack, followed by non-stimulant medications. These restricted diets tend to do moderately well, about 0.5. Artificial food exclusions do a little bit less well, and then some of these computer-based cognitive tests, neurofeedback, do less well. And then we get to omega-3 fatty acids, which, remember, the level of evidence, the quality of the evidence is as good as it is for stimulants, but the efficacy of the actual treatment is fairly low. It's less than 0.2. So remember, we have to keep in mind that here we're talking about the quality of the evidence, and even though the quality of the evidence for omega-3 fatty acids is the same as it is for stimulant medications, you see from this slide that the treatment effect is much greater for stimulant medications than it is for the omega-3 fatty acids. Both types of treatments have been subjected to very good randomized trials and meta-analyses and systematic reviews of these trials, and what we know from that now is that we have very good sense that they both work, but the medications work better than the omega-3 fatty acids.
Steve, can you give us a little detail on restricted elimination diets? What is that showing? It seems to have a decent effect size.
I'm glad you asked about that, because there's still a bit of controversy about those diets, and some would argue that maybe the effect is actually a little bit lower because they toss out some other studies as not being good studies. The main problem with the diets for ADHD is that they can be fairly extreme. Restricted elimination is basically putting the child on a diet which is removing many common foods from the diet. I don't have a list of those foods right now, but what I can say is that it's not an easy diet to do because it's many of the foods that a child would naturally eat and can't eat. It's not just junk food. We're not just saying get rid of junk food. That's something every parent should try to do for their kids. But these diets are different types of foods that the child might have a food allergy to.
Mm-hmm.
And that's why it's difficult. The parent has to be very rigorous in maintaining this diet. It's one of the reasons why it's difficult to do a blinded study, because these kids are eating a very unusual diet, and sometimes they talk about it when their symptoms are being rated.
Mm-hmm.
So it's not really a recommended method, because it's really hard to maintain a child on a diet like that. You have to have a very committed parent to doing that. And then
Mm-hmm.
you have to deal with things like the child goes to a birthday party, your family goes out to eat, and so forth. It's very difficult to maintain.
Mm-hmm.
We're going to shift gears a little bit now and talk about a study that Gene Arnold did on long-term outcomes. Now, important here is to remember that these long-term studies in almost every psychiatric disorder are typically not controlled. It's not possible to have a long-term controlled study of any treatment, because that would mean somebody would have to be on placebo for a long time, which is not ethical. So the best type of evidence we have from long-term studies are these observational studies of the type that Gene reviewed here in a systematic review. And here he's looking at a number of different types of outcomes, things like driving, self-esteem, social functioning, academics, antisocial behavior, obesity, addictions, health service use, occupational functioning. It's a complicated slide, so I'm going to walk you through it. On the left-hand side, we'll start. There are three treatment types. There's pharmacologic, non-pharmacologic, and what he called combined treatment, and that means somebody's getting both. They're getting a pharmacologic treatment, and they're also getting a non-pharmacological treatment at the same time. So what's kind of interesting here in this study, this is naturalistic treatment. This is not treatment by experts in ADHD. This is naturalistic treatment studies. What he found is that there was a wide range of outcomes for the pharmacologic treatments. This 0.8 is a effect size. He called it large, and it is. It's a fairly big effect size, which is what you'd expect from a stimulant medication. And so some of the effects for individual studies are very big, and some of them are lower, and that's what we expect. There's some natural variability among studies for the pharmacologic studies. For the non-pharmacologic, we see what we would expect from what I've shown you, is that the effect sizes tend to be lower than they are for the pharmacologic. And when he looked at the combined group, what he found was there's, again, a very wide range of outcomes. There are some very, very good outcomes up here, but it's hard to say from this that the combined is much better than the pharmacologic, but it looks like it might be a little bit better. And this is a case where evidence is hard to read, and one has to make judgments. You'll learn more about how I think we should use non-pharmacological treatments in combination in a little bit in this presentation. But for now, what we can say is there's some evidence here that combined treatments can be useful, but it's not that dramatic. There is some evidence there. Remember, this is here comparing a treated ADHD group with their pre-treatment baseline. So this is, are they getting better than they had been? Here, we're comparing treated ADHD on the right with a non-treated group. Now, unfortunately, there was no combination treatment, so he couldn't compare them. But he could compare pharmacologic and non-pharmacologic, and here he shows what we would expect to see, that the non-pharmacologic treatments are not doing as well as the pharmacologic treatments for the longer-term outcomes. And the long-term outcome is one of the more difficult problems in all of psychiatry, and especially for ADHD. And one of the reasons the pharmacologic treatments don't work in the long run is lack of adherence. People not adhering to their treatment regime makes it difficult for these treatments to work. The same is true for the non-pharmacologic treatments. If patients aren't doing their cognitive training, or if they're not recalling their cognitive behavior skills, for example, they're not adhering to their treatment, and the treatment will begin to lose efficacy over time. And this is, remember, this is a 2-year period. More data from the same study. This is looking at, he was looking only here in children and adolescents. He's looking at the percent of long-term outcomes that are showing some benefit based upon the age of the person. So the way to read this graph is to, let's just really look at the blue bars. This is the percent of the long-term outcomes that are showing benefit in blue. So we see, for example, for the pharmacologic treatments in the long term, that 48% of the treatments are showing a benefit. Now, for the non-pharmacologic treatments, about 58% are showing some long-term benefit. Now, remember, the actual magnitude of the benefit is lower. Here he's just saying, are they showing benefit or not? Mm-hmm. The magnitude is lower, but they're showing, more of them are showing benefit in the long term. And interestingly, the combined treatments are showing the most benefit. And that's quite interesting, because it might mean that people using combined treatments are more likely to adhere to all their treatments, which we expect to lead to more benefit. And we see a similar pattern in adolescents, although the combination effect is not seen for adolescents. But this is another reason why we think that including non-pharmacologic treatments could be better in the long term, is that it may be improving the long-term outcome by possibly improving the adherence of people to their treatment protocols.
Mm-hmm. I think there's evidence that has shown that long-term use of medication and possibly these non-pharm treatments actually improve long-term effects like brain size, for example. Do we have evidence about the long-term outcomes of using medications or non-pharm treatments?
Well, we don't have a lot of very long-term data on the non-pharmacologic treatments. There have been some observational studies of kids growing up over the long term, so say from childhood into adulthood, where a number of groups, including myself, have looked at the effects of medication over the long term. Mm-hmm. These studies are not controlled studies, but as I said, it's impossible to do controlled studies. But what they show are quite interesting. And in many areas, for example, substance use, we find that children who maintain their treatment over time are less likely to abuse substances in adolescence or adulthood. There's some contradictory data. The real important point there is that there's no evidence that using stimulant medications create substance abuse. That was a worry we had about 20 years ago, that maybe give kids abusable substances, they'll be drug addicts. Absolutely no evidence for that. If anything, there's some evidence for an improvement of substance use outcomes. We've seen in schizophrenia, kids that are treated with their ADHD on stimulant medication are less likely to be depressed later on in life. It's seen for a number of functional outcomes. Very remarkable data based upon very, very, very large samples in Denmark and Sweden, where they have these national registers that they can interrogate, have shown, for example, that kids that are on medications are less likely to have accidents. Oh, this makes a lot of sense because we know that ADHD kids are inattentive. We know they're at high risk for accidents. And now we know from these long-term observational studies that the kids that are put on medications, but not just the kids, adolescents, adults on medications are less likely to have accidents. They're also in adulthood less likely to show some of the criminal outcomes, the antisocial outcomes that are associated with ADHD. Mm-hmm. In one very well-designed study out of Sweden, they showed that ADHD people who maintain their medication were less likely to commit crimes than ADHD people who did not. Mm. And even when they looked at ADHD people, they compared their times when they were taking medication versus when they were off medication. And they were more likely to commit crimes when they were off medication than when they were on medication. So there's a lot of good observational studies that show that there are long-term benefits of medication. We just don't have those data for the non-pharmacologic treatment, so I can't really tell you much about that.
Right. And I was going to ask the opposite question, and I think you partially answered it. Is there evidence or studies that show that people who go off their medications actually have symptoms get worse and outcomes get worse?
Well, yes, because in the studies we're talking about, that's just the obverse of what I talked about. So that people who are on medications are doing better, the people who are off medications are doing worse.
I see. So there's like a control group there.
Exactly. And sometimes you can even use the patient as their own control, so that in some of these studies, the patients, while they're taking, in periods when they're taking their medication, they're doing better than periods when they're not taking their medication.
Right.
It's really very convincing evidence that there are good long-term effects of medications. Mm-hmm. So next we're going to talk about what I call a meta-algorithm. And this is really a way to think about how to integrate pharmacologic and non-pharmacologic treatments. And remember, if you're a primary care doctor, you may not do non-pharmacologic treatments. We're not saying you ought to be able to do them, but you can refer your patients for non-pharmacological treatments in many cases. So you do need to have some idea about how to integrate those into a really, if you will, optimized treatment program for people with ADHD. The first thing I'd like you to consider is the difference between what I consider to be broad-band treatments and narrow-band treatments. So a broad-band treatment is used to reduce ADHD symptoms and associated functional impairments. This is like a medication or an omega-3 diet. The goal there is we want to reduce symptoms and then anything else that the symptoms are associated with. A narrow-band treatment is one that's focused on something very specific, and that it could be a very specific set of behaviors or symptoms or impairments. We might say we're trying to, this child is too inattentive in school and we're trying to change that, or this adult is having difficulty driving to work and we want to focus on dealing with behaviors that are involved in driving to work. That's a narrow-band treatment. Examples of treatments that can be used for these narrow bands are things like social skills training. You teach somebody some very specific skills. Here's, for example, let's say you have a patient who maybe doing well on their ADHD medication but is still having difficulty socializing with colleagues at work, they might need social skills training, as an example.
You showed before on a previous slide that cognitive training is very good at helping verbal and visual memory.
That's right. That would be an example of a narrowband treatment where you can improve a very specific aspect of a person's ADHD and without necessarily affecting their ADHD symptoms in general.
Right.
And again, just as a reminder to the people listening that the cognitive training via a computer for working memory is different than cognitive behavior therapy, which is something a therapist administers to help a patient learn to be better organized and to cope with their symptoms. And it's a bit of confusion in the language that's used, but cognitive behavior therapy different from cognitive training, which is computer-based. Okay, so broadband, narrowband. We'll keep that distinction in mind, and that will help you understand this fairly complex algorithm, which I will walk you through from the top. So, number one, treatment typically starts with some education with the patient about their ADHD and the treatments that are available. The first decision one needs to make is, are medications indicated or not indicated? So let's talk about why medications would or would not be indicated. Now, typically, medications work in all cases of ADHD, so you might be asking, well, why would you not use the medication? Well, you might not use the medication because the patient does not want to use the medication. That's usually the main reason why medications are not indicated, because the patient says, Doc, I don't want to use drugs. I want to do something else for my ADHD, and you just can't use the medication. Well, in that case, we go to the right, and we say, okay, drugs are not, we can't use drugs. Well, then we would start with a very broadband treatment, because you need something that's going to control everything in this patient's ADHD life, all their ADHD symptoms and all their impairments. So we start with a broadband treatment. And once we implemented that broadband treatment, we then follow this arrow down, and we say, well, did we get a response from that treatment? What was it? Did we get a full, what I call a full broadband response? This patient's ADHD basically gone away, have their impairments gone away. If that's the case, you get a full broadband response, all the symptoms are gone. Then you ask the question, well, is there anything left in their life that's not working out well? And typically that's something the patient might complain about, so you'll hear about it. They might say, geez, everything seems fine, but I still have problems talking to people at work. And what can I do about that? Well, in that case, you probably would refer them for a treatment, some narrowband non-pharmacologic treatment that would help them with their specific problem. You follow the arrow down here and say, well, did they get now do you have a full response in terms of all the ADHD symptoms and associated impairments plus this narrowband problem the person is having? Well, yes, if things are going well, you move to the right, you just monitor and adjust medication as needed. If things aren't going right well, you do some more narrowband trials and you iterate there until it's solved. And again, it might not be that you may not be the person giving the treatment, but you may be referring them to a psychologist, a social worker, even an ADHD coach in some cases, to help them do better. So this is the way we use this meta-algorithm. To just try one more time, if a person is happy to use drugs, we go to the left, and then that would mean medication trials, and then we follow the same pattern. Is the medication treating everything? Sometimes it does, but sometimes it doesn't. Treating the ADHD symptoms to the point where you're happy that they're all gone, in which case you can then go to look for narrowband problems. If there's still some ADHD symptoms left, you might look for some other broadband non-pharmacologic treatment to help out. So you've seen how one can step through this algorithm fairly easily. The main point to take away is that based on the quality of the evidence and the magnitude of treatment effects, starting with an ADHD medication is usually the best place to start. We haven't talked here about sequencing medications. There's a whole other, there are other programs at ADHDadults.com which talk about how to do pharmacologic treatment. That itself can be complex because one may need to try different medications before one gets to one that works. But here we're just saying, where do you start? And what I'm saying is start the treatment that has the best level of evidence and that has the best efficacy, and that's medications. And then you can sequence, because then you can find out what are the drugs not treating. When you see what the drugs are not treating, that will help you decide upon the next non-pharmacologic approach that you might take. Okay, well, that ends this talk on non-pharmacologic and evidence-based medicines. There's a lot of people who contributed to this. These are all contributors to this book that I edited with Kevin Anschel. So all these authors provided some information that I use to describe the effect sizes of treatment and the quality of treatment evidence. So I'm thankful to these co-authors for their help in that.
So we've been talking with Dr. Stephen Ferrone, PhD from SUNY Upstate Medical University. We've been discussing the efficacy and also the quality of evidence for using a combination of both pharmacologic and non-pharmacologic treatments for ADHD. It's been a very interesting discussion. This whole area of non-pharma treatments for ADHD is growing. We do have other sessions on our ADHD in Adults website on meditation, on exercise, and so a lot of this evidence is coming to the fore in terms of both efficacy and the quality of the research that's being done. This presentation has been brought to you by APSARD, the American Professional Society of ADHD and Related Disorders. We're accredited by NACE, the National Association of Continuing Education, and this is produced and distributed by Inkwell Medical Communications. Steve, thanks so much for being here and for all the wonderful work you do in this area of research and treatment.
You're quite welcome.